Thank you so much to Sages for allowing me to talk. Obviously, I'm presenting a minority opinion today. I do a lot of everything, and a lot of gastric bypasses too, but the one anastomosis gastric bypass has certainly taken hold of my practice, and I'm going to invite you to reconsider it. This is the nomenclature you need to know. Mini gastric bypass is the historical name more. One anastomosis gastric bypass is the same thing, and the omega loop bypass. And I use these kind of interchangeably, so I apologize for that, but they're all talking about pretty much the same operation. These are my disclosures. I'm a HCA kind of employee because I run a foundation of surgeons. We have 3 Center of Excellence, hopefully a 4th. I do training and lecturing for Ethicon, a lot of teaching for sleeves, and now a little bit of the mini gastric bypass. I work on technologies and remote learning with them. I work for a company called Medical Education Resources where I educate only medical professionals around the world on obesity options, including surgery. And I want to mention my mentors, not just to be nice because they're pivotal in this discussion. Helmuth Billy, you all know, he's wonderfully passionate. And he came to me 5 years ago and said, hey, you should look at this mini gastric bypass. It's pretty cool. So I started to look at it. And so he really was the genius behind the thoughts in this. I went in January 2019 to Cologne, Germany to learn from one of the masters, Karl Reinwald, and I learned how to do the procedure standardized and well and care for the patients, so I really owe him a lot. And I have been in contact with Robert Rutledge, who's the inventor of the procedure. Clearly, he's a checkered presence in our societies, but it's still something we should talk about in a little bit. I'll discuss him with you. I want to talk about your disclosures. It's all about the A. SAGES, ASMBS, it's all American, American, American. The reality is there's no real great American data that we can accept, so it's going to have to be the international data we use for this, which is appropriate because they have the most experience. Atul Gawande, I don't know if you know him, but you should read his stuff. He says it's not that anyone can do surgery that's interesting, it's that anyone does surgery that's unbelievable. So the fact that we have the hubris to plow into bellies and rearrange and take out stuff and staple stuff and remove stuff to help people's life and health is pretty amazing, because that we wouldn't do it unless ethically we felt it was the right thing to do. And the reality is we're wrong a lot. I mean, 30 years ago, ASMBS was all about VBG versus bypass. And then when Whitgrove presented his laparoscopic bypasses, everyone thought it was unsafe. And the band was the best option. I've done over 2,200 of them, but I was wrong. Roux length used to be king, but now it's pancreaticobiliary length. And robots, they're just an expensive toy. No, actually, they're a critical part of a good surgical armamentarium in a lot of practices. The Sadie is too much, Cottam and Rosalind are nuts. No, it actually has its right place in bariatric surgery. The OAGB is just not effective and it's not safe. Well, maybe we're wrong on that. And maybe your passions are against Rutledge. This has nothing to do with him, except he's the genius behind the procedure. The sleeve is blowing up. Ethicon data from 2014 till 2025, it's going to triple in popularity. The sleeve has just overwhelmed us. It's amazing. All our talks will be sleeve talks eventually. Maybe not. Israel data, 5-year data from February 2020 in obesity surgery. They studied it and they found the mini gastric bypass was introduced in 2014, 0.1% of cases, and by 2018 it was 46%, decimating the sleeve. And if you look at this data, this is a lot how it looked like when the sleeve ruined the lap band. So the MGB is coming on hard and it's here to stay internationally. Critical components of any bariatric surgery: it has to be effective at weight loss, comorbidity resolution has to be on point, it has to be safe, durable, and reproducible, easy, and standardizable. I think those are important. I'm not going to talk about them today. But I invite you to go to your PubMed and look up times and places where the Roux-en-Y gastric bypass is more effective at weight loss than the OAGB, and you'll find none. A 10-year experience shows the mean BMI was much better in the MGB, and the excess weight loss was much better over 10 years in a broadly published study. And they did a meta-analysis of 12,445 patients, including a number of randomized controlled studies, and they found at 1, 3, and 5 years, the OAGB weight loss was better than the bypass. But then I was at the surgery talk 2 days ago with Dr. Schauer, and he was talking about weight regain after bariatric surgery. So my wonky slide is because I took it from the right side of the audience, and he was talking about with OAGB and sleeve, you got to figure out how to deal with the weight regain. He didn't mention the bottom line OAGB. It wasn't a subject with them. The line is flat, and it wasn't even mentioned in his talk. But the reality is OAGB, it wasn't a problem. It's more effective in terms of comorbidity resolution, and this is really important. I can talk about it in every parameter, but the reality is diabetes is really where we make our mark. I think that's what we do is, we're blessed and honored to have the miracle of diabetes resolution in our armamentarium. And what they did is they studied 3,678 articles, including 25 of the wholly randomized controlled trials, and they studied all 8 bariatric procedures that are done, and they found that diabetes remission was much better in the OAGB, better than the SADI, and better than the Roux-en-Y. And if you look at the data, I know this is a busy slide, the second category over, 86% of mini-gastric bypass patients had diabetes in remission, and if you go down to bypass, it's 64%, and the sleeve is a little bit embarrassing. It's safer or as safe? That's the big question, and we always hear to vilify the OAGB for reasons that all of us hear about but don't study. Carl Reinwald, one of my mentors, studied this, and he studied OAGB versus Roux-en-Y gastric bypass. Intraoperative complications, pretty much the same. Early relaparoscopy, the same. Leakage, the same. Let's skip to marginal ulcers. A little bit better, but not a big deal. Internal hernias, there's a lot of people who say you should always do SADI because internal hernia risk is too great and too dangerous, and it's quixotic and a lifelong problem. With the mini-gastric bypass, we don't really see internal hernias. A lot of people are going to be embracing the loop procedures just to avoid this potential catastrophic complication. I'm not advocating that, but I'm saying it's something that needs to be recognized. The loop procedures have less internal hernias. And it's more durable than the bypass. 1,731 patients versus a prospective bariatric database. The revision rate was a little bit less in the mini-gastric bypass. Then the Roux-en-Y, if you look at a 5-year weight regain out of the 10,000 patient study in India, over 5 years, the weight regain was 15% in bypass patients and 3% in mini-gastric bypass patients. And we won't even talk about sleeve. So weight regain is a much bigger issue. In summary, the OAGB is more effective, better comorbidity resolution in terms of diabetes. I did not mention the others, but I will if you invite me back. It's as safe and it's more durable. But my opponent's going to talk about the Y omega study, and I'd like to call it the Why Bother study. It's the study that's been foisted as the #1 reason why you shouldn't do it. It ruined mini-gastric bypass in France. And I got to tell you, it's one of the crappiest studies you'll read. It's 250 patients. Excess weight loss obviously is better with the mini-gastric bypass. But if you look at the serious adverse effects, 1 in 3 in OAGB patients and 1 in 5 in bypass patients, you would lose your center of excellence with this kind of crappy results. But if you look at the operative complications they talk about OAGB, 4 hemorrhages, 2 bowel injuries, and 2 stapling the NG tube in place. I'm sorry, that's not a problem with the procedure, it's a problem with the surgeons doing the procedure. This is a B2 operation. You should be able to do it without this volume and intensity of problems. And early and late surgical complications are similar. The average length of stay was 5 days in both. So we're not comparing apples to apples. We're doing rotten apples to rotten apples. I would lose my insurance authorization for all procedures if I kept my patients in-house for 5 days or needed to. And they didn't standardize the OAGB. The OAGB is a very standard procedure in terms of how you do it and the length of the pouch, and it wasn't standardized, so that increases problems. But if you look at the problems they had, 4 out of 6 of their bad reflux patients, quote unquote, had LA grade A reflux esophagitis. Sorry about the typo, but that's not really GERD in the Lyons criteria. And in terms of malabsorption, it wasn't fair. Everyone got a 200 centimeter biliopancreatic limb, and the way everyone is doing OAGB around the world, 200 centimeters is very long. People with 35 BMI got a 200 centimeter BP limb. That's wrong, they didn't do it right. But the big boogeyman you're gonna hear about is bile reflux esophagitis causing cancer, which once again, PubMed it, you won't find it. But we've been worried about it since the B2 was invented in the 60s. And 16% of the patients scoped in the study that had a mini-gastric bypass had, God forbid, bile in their pouch. Of those, if you read the study, it had 0 influence on their quality of life and symptoms. It was a pathologic finding, and not one of them needed a revision for it. So once again, vote now, vote often, OAGB. Thanks.